Thank you. And Megan, if there's anything more you'd like to introduce about yourself and your background, and then just take it away. Thank you very much.
Sure. Thanks so much. As you said, my name is Meghan Engbretson. I'm the manager of infection control here at the Children's Hospital of Eastern Ontario. And I wanted to highlight one of the projects that we're doing that really sort of highlights the role of families and caregivers, including parents, as partners in infection prevention and control. So a little bit of background about CHEO for those of you who may not be familiar. I know we're spread out a little bit across the province. The Children's Hospital of Eastern Ontario we actually just had our 50-year anniversary last year. We have 156 funded inpatient beds, including a level 3 NICU in Ottawa, Ontario. And on a yearly basis, we get about 7,500 admitted patients, and 750,000 outpatients per visit. We have satellite services located throughout Eastern Ontario, as well as Northern Ontario and Nunavut and Western Quebec. So we have a fair amount of reach in an outpatient capacity, but we also have a medical day unit for dialysis. We have a small dialysis program. We have an outpatient chemo program, as well as operating rooms, an emergency department, that kind of thing. Today, I wanted to talk a little bit about the role of family and caregivers can play in infection control, and review the benefits as well as the challenges to engaging those partners, as well as identify some opportunities maybe to incorporate caregiver engagement in your practice or future practice, and apply some lessons learned from our AL-CIP, which I'll get a little bit into in the next few slides, which is our project or initiative that we're working on right now. It's an ongoing project. Okay, so I just wanted to start off by saying that I think the way that we view caregivers and parents, and this is not specific to pediatric care, but it certainly plays a large role in any sort of pediatric environment. When we think of who is closest to the patient on a regular basis, it depends on the patient, but often you'll have parents, caregivers, whether that be legal guardians or extended family members, sometimes even visitors, doing roles that are having overlapping roles with healthcare providers. So they occasionally will do bathing and feeding, as well as sometimes line care. So in central lines, as device management, things like IJ tubes, things like that. Diaper changing, helping their children use the toilet, dressing them, comforting. They spend a lot of time generally with their children, more time than we spend with them. So I think the aim of this presentation is to talk about how can we see or change our mindset to see caregivers as an underutilized resource in infection control. And this kind of frame shift has been ongoing over some time. If we go back to sort of the mid-70s, 80s, we started to see the emergence of a family-centered care mentality. I think you may have heard family-centered care before, and I think that a lot of hospitals, especially pediatric centers, are trying to embrace that where they can. And this started with sort of letting the fathers into the delivery rooms for labor and delivery, babies staying in the room with mom instead of going directly to the nursery, as well as siblings being involved in patient care. So that was a bit about the beginning, and that has evolved over time. I think where we saw this really come to a head was during COVID. Some of you may or may not have been involved at that point, but we really saw, I think, the risk of having caregivers and family members and visitors at the bedside. We tried not to completely exclude them, and in a pediatric center at CHEO, for example, we allowed parents one at the bedside, one at a time, for the entire pandemic. Obviously, you can't stop parents from coming in and being with their children, but I know a lot of adult facilities had stopped any sort of caregiver or visitor presence because they felt that the risk of bringing in a respiratory illness like COVID into the hospital was too high. And we saw that impact a lot of, especially in long-term care, that lack of caregiver presence was really evident in the quality of life for the patients and quality of care, as well as patient safety. Um, and that's when we sort of started to, a lot of centers had to sort of firmly determine define who was a caregiver and who was a visitor, and really evaluate that risk versus benefit to the patient and to the facility. Um, since then, or I mean, even before then, we've worked on seeing caregivers and parents and visitors as a more of an engagement and active partnership with these roles. Their presence at the bedside, especially if we're talking about parents, caregivers, is largely unchanged, but we're working on changing our understanding or understanding more about their role. And we recognize that we have the opportunity to utilize this role as a partner in infection prevention and control. That's just a bit about how we sort of got here to where we are. When we initiated our project, the Enhancing Quality Infection Prevention, which is AQUIP, the acronym, we wanted to do a bit of a literature review and environmental scan at some different pediatric care hospitals to see what other facilities were doing in terms of engaging caregivers. And some things that we took away from the literature and from those conversations was that caregiver hand hygiene is consistently poor across the board. You'll see figures anywhere from 3% to 50%, but it's consistently reported to be less than 10% compliance rate. So that's, less than 1 in 10 opportunities for hand hygiene they're taking to clean their hands, which is not great. We here at CHEO had actually done a few studies in the past where we measured caregiver hand hygiene compliance by having an auditor stationed on the inpatient units and observing the moments for hand hygiene, generally entering and exiting a patient room, so moment 1 and 4, and recording that compliance rate. And in the past, the one study I believe was in 2019, we saw less than 5% compliance rate over a time period. So lots of observations in that one. And then we actually repeated the study 2 years ago, same technique, but we actually, the time period in which we conducted the study was during what we would call peak viral season. So during the winter season, when the burden of respiratory viral illnesses is really high in the hospital. And we had applied a universal masking policy. So any patients or parents, caregivers would have to mask when they were outside of their child's room. So despite the high, the respiratory illnesses going around, we also, in the middle of the study period, had an outbreak of norovirus on the units that we were observing. So it was really interesting to see. We wanted to see if the outbreak signage and the communication to families would bump up that hand hygiene rate, but it didn't. Unfortunately, we saw the same less than 5% hand hygiene compliance rate. So there's definitely some room for improvement there. One thing that we did notice was that the parents were greater than 90% compliant with the masking, which was really nice to see, because I know that some of us will have seen struggles with patients and visitors with masking coming out of COVID. We also know and have learned that caregivers believe that they play a role in preventing infection and in their child's safety out of the hospital and in the hospital. And they do want more education. So they're teachable, they're willing to learn if you take the time to teach them. We've also seen, or it's been demonstrated in the literature, that interventions in caregiver hand hygiene compliance they work, they have positive effects in hand hygiene compliance, and actually interventions targeted toward caregivers have been shown to affect healthcare worker behaviors, so increase the healthcare worker hand hygiene as well. So those were our takeaways when we were going into this project. And I just want to talk a little bit about what we hope, or what we are hoping to achieve with this. We want parents and caregivers who are staying at CHEO with their child to have a knowledge and understanding of the role the infection control program plays at CHEO. We want them to understand some of what we do to keep their child safe from infection when they're in the hospital. We want them to feel like their role is appreciated and that we understand the importance of them being here and partnering with us in these efforts. We also want to make sure that they have a true understanding. We get children from all over, and we have a very diverse patient population and a wide variety of languages that are spoken. We have a translator service, but we want to make sure that that everybody, regardless of the language that they speak, has a thorough understanding of what is happening to their child in the hospital, as well as the ability to ask questions specific to IPAC practices. So if they're placed on precautions, on isolation precautions, if they're placed in a room with another child, that can be a stressful thing. We want them to have an understanding of why that happens and how we're keeping them safe. We also want to give them the opportunity to provide feedback so that we can continually improve the effort that we're making. So this is a program that I'm not sure if anyone has heard of, but it's out of Alberta Children's Hospital, and so their program's called the VIP, Volunteers in Infection Prevention and Control Program. And this is really what we modeled our program after. This picture is from an article in Global News a few years ago where they were making an effort to recruit volunteers. And this particular effort was towards increasing awareness of respiratory and gastro infections, and the role that parents and caregivers can play in their children's care. So we had the opportunity to meet with this team out of Alberta and get some advice and some materials from them so that we weren't totally reinventing the wheel, and then we adapted it to our facility. Okay, so this is a bit of our project plan, and I'll talk about a little bit about what we have done so far and what we're still working on. Like I said, we redid some of the audits so that we had a baseline hand hygiene compliance rate for caregivers. For healthcare workers, we do audits on an ongoing basis, so that's kind of a rolling thing. One of the pieces of advice that was given to us by the Calgary VIP program was to consult the Family Advisory Council. It may be called something different at other hospitals, but that's what we call it, for their input. So generally, that's a group of parents or former patients, current patients who meet and provide advice to the hospital based on their experience. We also knew that we wanted to review the written materials and online materials that are provided to parents and caregivers when they're admitted to the hospital to determine whether there was room for improvement, whether there was any gaps. And I should mention that when we initiated this program, it was with the help of a previous practicum student, not through Queen's. She was actually at Humber College doing their IPAC program. So she was the one that was sort of spearheading these efforts. She was with us for 6 months doing her co-op. Right, so communication review. Currently at CHEO, when a child is admitted, we do have in-house volunteers who go around and they try to reach, I think it's 20 or 25% of the new admissions, to give them information about their stay at CHEO. So information, they get a bunch of brochures and QR codes to links on the external page, that kind of thing. And they talk about, dining services at CHEO and parking and logistical pieces. And there isn't really anything in there about infection prevention and control, other than they will touch on if there's a mandatory masking policy in place, they'll talk a little bit about that. But it's generally a quick drop off, and it doesn't have an IPAC focus. So we wanted to expand on that a little bit. We also took a look at our external CHEO website, because through COVID, the information about IPAC in the hospital and suggestions and tips for parents sort of got a little bit spread out everywhere. And we knew that we wanted to consolidate that so that we could give one link to one page to parents if they wanted to, if they weren't in a place where they were digesting information at the time we were talking to them. If they wanted to reference something later, then they could go back and they could look at that. What we are planning first, and we haven't, our plans are in place. We haven't executed the pilot yet, but what we are planning to do is to do a pilot on 1 or 2 inpatient units, where we will hold a conversation with, again, new admissions in the first 24 to 48 hours. We will give them an opportunity to ask questions about and answer some commonly asked questions about IPAC in the hospital. We are designing a brochure to give to them, so they have something written, as well as links to, like I said, that one central source on the website for information. Going forward, we are hoping that we are able to recruit volunteers to do this. That comes with its own challenges, but I'll talk about that a little bit later. We are putting together a training program for the volunteers who will be holding these conversations. And we're hoping that our pilot allows us to get some feedback from parents and caregivers as we do it, or even from staff to say, yes, this is working, no, it's not working. Some of our older patients as well, those who want to participate. And we can revise those materials based on the feedback as we go. And then eventually we'd like to do some follow-up audits to see if it has made any difference in our hand hygiene compliance. I just want to touch on the Family Advisory Council for a minute because it tends to have some really interesting insight. Our FAC is 25 parents, caregivers, and former patients who meet with senior leadership every other month for a few hours. And they provide input, feedback, guidance across various programs within the hospital to ensure that family-centered care, patient-family perspective is included when we're making decisions in decision-making in the hospital. They had a number of different great recommendations for us. Their first recommendation was to engage kids, typically older kids, but engage them from the start so that we could get feedback from the parents and the kids. They also mentioned that they thought the kids might be good they might be reminding the parents, oh, wash your hands, that kind of thing. I guess they've seen that kind of behavior before. We also talked a fair bit about diversity, equity, and inclusion and how we could come at these types of conversations with the appropriate sensitivity and how we could address the language barriers, knowing that we do have a translation service, but I've heard anecdotally that it's not the best. So we are, and I think they had just switched to a new service. So we're working on that piece. How do we reach the most parents and caregivers possible while still maintaining this approach? They mentioned that they wanted both written and online materials as well as video materials. We haven't really explored the video piece yet. And they also highlighted that they would like to continue to give feedback throughout the life of this program, which is really great. That's what we want as well. They bring up things that you wouldn't necessarily have thought about. For example, we say to the parents and caregivers of the children who are hospitalized that the bathrooms in the rooms are for the patients, not for the parents and caregivers, and we direct them to a separate bathroom outside the patient room in the hallway. So the FAC brought up that they actually weren't sure whether they were allowed to use the separate hand hygiene sink in the room to wash their hands, because we had said don't use the bathroom, but we hadn't actually talked about the hand hygiene sink. So just things like that you wouldn't necessarily think about. Like I said, we are planning to approach parents and caregivers within 24 to 48 hours into their admission. In a previous study that we had done, caregivers had indicated they wanted to be approached within the first 24 hours. When we met with FAC, they thought maybe that might be overwhelming depending on what kind of admission. So I think it would have to be sort of a judgment call based on what the kid is here for and whether it's a repeat admission or whether they've never been here before. Our brochure is currently in progress, but during this conversation that we are intending to hold, we want to talk a little bit about hand hygiene, both the technique and opportunities. So when they should be cleaning their hands and when they should be using alcohol rub versus soap and water. We also have this cute hand hygiene song that is on YouTube that one of our pediatric infectious disease doctor created. So trying to think of different ways to engage the parents and the kids. We also want to talk to them about masking when they're sick, or if it's at a time when we have a mandatory masking policy in place, when to do that, and then give them the opportunity to voice any barriers or ask any questions. I will say that we have already anticipated some challenges and experienced some challenges. The first being that generating, and this is likely not true for every facility, but generating patient-facing or public-facing written materials especially, but on the website as well, that tends to take a fair bit of time. We're going through our communications department and it has to be sent to translation and then back. It's been very time consuming, but I think it'll be worth it to have it in a number of different languages. We are also still working with our DEI group to ensure that we are approaching the material in a culturally sensitive way. We don't want to infantilize parents and caregivers and imply that they don't know how to wash their hands or make them think that we're saying that their hands are dirty, that kind of thing, negative connotations. We also, because these are volunteers that will be going in, we are likely recruiting from the Ottawa Med School, I think is the plan. And so we are aware that they may get out of scope questions either about their child's care, just because it's a human in the room. They want to ask questions about how their child is doing. We also know that parents we often have patients in double rooms. Most of our inpatient medicine rooms are double rooms, and that can be stressful for parents. They tend to not love it. Unfortunately, we can't give everybody a private room. We just don't have the facilities to do that. So we don't want any angry parents coming at our volunteers if it's out of scope. So working on ways to train the volunteers to be able to engage help when they need it and to direct families to the appropriate person if they're not the right person to answer that question. We're also still revising how we want to make note of these visits, whether we want to document them in our electronic health record. It's just something that we're considering for the future. And I'm sure we'll encounter some challenges along the way as well. But yeah, that's sort of where we're at right now. We're waiting on the hard copy of our brochure before we start our visits. And we're excited about getting the program started. I have some relevant references and papers here at the end that I can include with the slide deck if you want to send that out after. But that's about it for me. Wondering if there's any questions or anyone wants to chat about anything specific to parents, caregivers, that kind of thing.
Thank you. Thanks, Meghan. That was great. And we had some informal chatter as we were starting, and I work in geriatrics, and a similar initiative and model to engage family members in recognizing and managing delirium. So I think I totally agree that families and caregivers are an under-recognized resource towards wellness in all capacity. And I love your acronym, EQUIP. That's great. I see there's a question from Laura.
Yeah, can you hear me okay?
You
Yeah.
can.
Okay. Thanks so much, Megan. That was a really great presentation. I'm one of the IPAC MPH students. I'm just curious how hand hygiene audits look for like patients and families compared to for staff members and how they might look different or the same.
Yeah, good question. So it's pretty similar. We use the Handy Audit tool, and we have an auditor stationed on the units. They generally will introduce themselves at the nursing desk, so it's not like a covert audit, but they're also not wearing, a bright orange vest that says auditor on it. And they will walk around and wait for parents, caregivers to exit the room, and they'll try, and it's not perfect because sometimes it's hard to assess whether the parent has used an alcohol rub farther into the child room where we can't necessarily see it. But they'll try their best to evaluate whether the parent has cleaned their hands before exiting the room or after exiting the room, and then again before entering the room, or at least prior to touching the patient environment or their child themselves. So it's pretty similar to the way that we conduct our staff audits. Um, yeah. Any other questions about the audit piece?
No, that's helpful. Thank you.
Hi, Lisa. I see that I was I was wondering about KHSA and their hand hygiene audit program, and whether there is consideration of extending it into family members. Just wondered if you want to comment on it. Thanks.
Yeah, no, we haven't extended to family members. We've kind of limited to those that we've provided education to. But I do have a question, Megan. It was a great presentation. Have you considered, or how are you going to handle patients that are on precautions? It's one thing when your staff are going and having these conversations, but when you have volunteers, you get kind of into sharing health information.
Yeah.
And not just about like being asked questions about their care, but questions about what they have and what that means.
Yeah, it's a good question, and we want to. It's a delicate balance to try and answer questions and redirect. Generally, our volunteers, so the volunteers that we already have at CHEO, will go into rooms on contact or contact droplet. They're not N95 fit tested, so they don't go into rooms with airborne isolation. And I imagine it would be pretty similar. So they know to redirect any questions about their child, the isolation or the health. The volunteers who we would be sending into the room would be aware of the isolation status as per like the sign on the door. But then I mean, we wouldn't share, like they wouldn't have access to Epic or anything, so they wouldn't have any other health information. But they would be able to, see what kind of precautions they were on.
So just for like awareness of the group, like a patient could be on droplet contact precautions for respiratory illness or because they have MRSA in their sputum. So the volunteer would be able to provide education and direction on the precaution. But you get into a situation there with really they wouldn't know or shouldn't know why that patient's on precautions, and we wouldn't want them answering any questions related to that.
Yeah, so that's why we're trying to keep it really high level, like just things that would apply to every parent, regardless of whether they were on isolation or not. So hand hygiene technique, we have the opportunity to bring glow germ as well, if there's especially the kids really like participating in that, you know, masking when the parents themselves are ill, when they're outside the patient room, stuff like that, where it shouldn't matter what isolation they're on. But obviously, yeah, there's opportunities for uncomfortable questions to come up, and we need to make sure that the volunteers are well versed in how to direct those for sure. Any other questions?
While people are thinking, speaking as the MPH program director, we actually have a course in kind of the methodology of program planning and evaluation. And this is certainly an issue that can be addressed using a program planning and evaluation framework as you did. Just around the key components, the activities, the outcomes. And often these can be strengthened with timelines as well. And instruments like using a Gantt chart or something can also be helpful. I know that you're kind of waiting for the resources before you pilot, but do you have a bit more detail on your timeline for this?
Yeah. We honestly, we've been waiting on on the brochure from comms, there's been some hiccups. We've been waiting for a few months. We thought that we were going to be able to start in April. And it's been a series of delays, but we didn't want to start and not have anything to leave the parents and caregivers with. We wanted to give them something physical. So we elected to wait for that, but hopefully we are able to start within the next few weeks. Our student from Humber is actually coming back as a research student, so she is going to continue those efforts and starting. So it's probably going to be her and myself doing the pilot piece. I should also mention that we are planning on checking in with the charge nurse prior to conducting the visits on the day of to make sure that there aren't any sensitive or social situations that we should be aware of or rooms that we should avoid for the moment to avoid putting ourselves into that kind of scenario. If the charge, they're often aware of whether there's complex social situations going on, that kind of thing.
Yeah, Megan, thank you. Thank you for mentioning that. In our program, we use the evidence to action cycle, and that adaptation of the model or the intervention to the context and contextualizing it is very important. So what you've offered is some insights in terms of setting the setting as you move towards implementing the program, and also the importance of piloting it. Sort of lessons learned. The other thing that I'm very sympathetic to, having been an AMOH, is how you do need to work with other aspects of your organization. Communications, extremely important.
Mhm.
And it goes in two directions, internal and external.
Yeah.
And very valued, but also does need thoughtfulness and care and often approvals. And so it can certainly delay implementation.
Yeah.
But usually the product is worth the wait as well.
Yeah.
Yeah. Good. Are there any other questions or comments? I'm looking in the chat as well. I'm also a little bit distracted because I'm afraid we've got someone in MS Teams waiting to join us.
Oh no.
Yeah. And again, I apologize to folks. And going forward, I've been trying to get rid of the MS Team link because these are Zoom meetings, and I put the Zoom in the calendar invite, but MS Teams is defaulting to their virtual link. So I apologize for that confusion. So we have just a couple of minutes. This is also a little bit of an opportunity for networking or checking in. Just wondering if anyone has any other comments on any other aspect of IPAC or what's going on. And if not, we're certainly looking forward to next week. And I believe that that is Public Health Ontario. I think David and Catherine might be presenting. So that will be very helpful too. And we have successfully managed to record this session. So we'll be sharing it out to everyone, including those who might be waiting in the MS Teams space. Megan, thank you very much for this. We greatly appreciate it. And hope that also that you continue to join us maybe in the upcoming series. I think we've got 3 more in the month of July. So thank you.
Thank you.
Okay. Thank you, everyone. Enjoy your lunch, and we'll see you next week.